interventionalists are earlier adopters, have more expertise in the technology. And the nice thing about a meeting like this is come together, learn from experts. We have live cases, we have case presentations.
The DCB is a technique that avoids the implantation of a metallic implant, and so we don't create the problem, and we have a technique that leads to a restoration of a normal anatomy afterwards. So this is a great thing, and with the current techniques, with the pre-dilatation, with the dual antiplatelet therapy we have, this technique is here to stay. And I think this is an important add-on to the current interventional techniques.
The reason that there's such interest in the community with drug-coated balloons is the potential long-term benefits. So I think we would all accept, all other things being equal, if we can get the same result over the short term with a drug-coated balloon as with a drug-eluting stent, then the long-term advantages speak for themselves. If we talk to colleagues in their cath labs, we're seeing usage, go from single digit to 10 to 20% of PCI volumes. Of course, we have enthusiastic adopters and expert centres who might use 60-80% drug-coated balloons. But I think there's a general increase in the use of drug-coated balloons across Europe.
After these 2 days, and it was really nice 2 days, I have the impression that more and more I have to find arguments in implanting a stent and not any longer arguments to use DCBs.
I think that in the future, drug-coated balloons are going to be most important to treat these long lesions and calcified lesions. So the hybrid approach, combining the stent and a drug-coated balloon, it could be the next step in the interventional cardiology.
This is most interesting for me for diffuse disease or concept leaving nothing behind, so only use the DCB and not necessary to implant the stent.
I think at the moment the interest is in de novo disease, and using drug-coated balloon angioplasty for de novo disease is attractive, particularly in situations where you're keen to avoid metal layers, multiple layers of metal. So bifurcation, PCI, small vessels.
The great thing is that we go back to the future. We all started with POBAs. We then were forced to use the stents. We now see that the stents have a problem, or can have problems in some patients, in some anatomies of the patients, like calcifications, like patients with diabetes. And now we have the possibility to use a new technique without a metallic implant.
I think one of the things we've learned in recent years is, previously it was drug-coated balloon or drug-eluting stenting. Well, I don't think they're really competitive technologies. They're rather complementary technologies, and what niches are good for DCB and which niches are good for regular drug-eluting stenting.
The sequent DCBs, they have the best data. The DCBs from the sequent group, they have now 2 different drugs. They have been compared. We know that both drugs work on this special device.
The sequent family of devices were the first to get CE mark, as far as I'm aware, and certainly the evidence with the sequent family of devices is much more significant than with other balloons.
The problem with the DCBs is that there's no class effect, so you have to prove with every device that it works, and with the sequent family of devices we know that they work and we have good data for it.